Hey,
Whoa, this is episode 26.
it is how quickly the time flies. And welcome to 2020.
Yeah, we're in the second half of 50 episodes, Alex.
That is pretty cool. So, and I just have to say, the last one was pretty good. I'm getting very nice feedback from it, and if nothing else, it gets people talking, right? So, what is that essence of what we do as professionals, and is it okay for someone to come in and actually start to identify that not everything we do is substantiated, not everything we do has the same value. Like it's not a pound of care is not worth the same as a pound of pseudo care. A pound of science is a
Mhm.
very different weight than a pound of pseudoscience.
This is kind of what we wanted to talk about today was the idea that until therapists have all come to terms with what it is that we do that actually impacts patient outcomes and what we do that are ancillary to that, and at least internally being able to separate the two. Even if some things that we do are to help facilitate being able to get patients to that end goal. But I kinda think of, like, 3 buckets, like, things that we do that are really useless, that are just to fill time in a session, things that we do that are to help get patients prepared for the things that are more, gonna actually help them reach their goals, and then things that are very, very right on the surface, scientifically proven to help them reach whatever it is their goal, as long as the goal itself is appropriate. If the if the goal is someone who has these, how many of these scenarios have we heard? An inpatient, somebody who hasn't walked in 3 years because of a stroke, getting them to walk independently, you can make that the goal, but it's completely unachievable. So there's always that goals and that fit the patient and are realistic.
Goals and expectations, right? Like,
Yeah,
well, it's managing expectations, but I think substantiating goals and building goals. I think the essence of science is asking the right question. I think if you learn to ask the right question, the answers are can be found. And that is exactly the point where we haven't met since Graham session. That would be a good quick giddy up
definitely.
to discuss. But at the Graham session we had a very interesting discussion, a panel discussion, which is that like what the nature of physical therapy trade and profession. So Larry Benz is to me probably one of the top five PT thought leaders that are worth listening to. And he was on a panel and having a discussion. So Larry has spent an entire career building musculoskeletal systems, now working as a CEO and a founder of Confluent Health, Evidence in Motion, one of the founders of Evidence in Motion, and just really having a fundamental origin in modern physical therapy. But then now he's transitioned to dental care. So he's the CEO of a dental company, and finding parallels in dentistry as an industry with physical therapy and some of the dissonance between both. And one is just a well-defined professional identity, which you and I discussed this. Like dentistry is a practice of like a mouth and everything around the mouth, right? Like there's a label for it. So it's so well defined that you know that anytime somebody works here, like it's going to be a dentist. It's not going to be a podiatrist, right? And if you have a podiatrist looking into your mouth, then you probably are in the wrong
You have
practice.
bigger problems.
Yeah, but with physical therapy, like we just have such a broad like range of practice. We have such poorly defined characteristics that it's it's tough to create value allocation to a payer or to anyone who is looking at our industry from an external lens, right? So looking through a microscope at a bacteria and finding who we are without that essence is difficult. And like so, reading what's his name? Nassim Talib's Skin in the Game, right? And like I know you like that quote too, that you cannot infer what the ant farm or ant colony does by studying a single ant. So you cannot infer what physical therapist does by studying a single physical therapy practice. But what are we as an industry?
I think this is an example of the value that you're bringing in talking about how somebody like Nassim Taleb thinks and relating it to something that matters to us, and we could and should do a lot more of that as a profession. The the professional identity question is, I think, one that haunts us and professions like us. I'd say even our medical sister or cousin, physiatry, suffers from the same challenges that they have, number one, fewer challenges because they're physicians and they're just in a, culturally viewed differently. But they do have a similar problem that we do in that there's so many subspecialties. If you want to think about physical therapy as a specialty, that is, we're like a specialty within its own profession. And each of those specialties has such completely different identities and frankly can't relate to each other real well. So an early intervention PT versus someone working in long-term care versus with someone working with sports teams. I mean, the treatments are different, the goals are different, what their incentives in providing care and in their day-to-day work are different. And it's almost like we lose the glue that makes us a profession. Okay, use dentistry as an example. Yeah, you're gonna have dentists that focus more on cosmetic or more on, periodontal or orth, but you're still talking about one part of the mouth, and they can all
Yeah.
do the basics well. We can't even agree based on generations even of therapists, those that graduated 40 years ago, most of them practice very differently and learn very differently than the ones that are practicing and graduated in the last 10 years. And then you silo those into their different specialties. And then folks who've never left the one area they've worked in.
Sure.
So this all leads to issues with professional identity that have probably harmed our advocacy as a profession to be what we could be given our level of education and what we legally are permitted to do in all 50 states.
And I think if you look into like there's a lot of parallels, right? So any dentist, so anyone who's a licensed dentist can practice all levels of dentistry in all 50 states. So your general practice dentist can do oral surgery if he chooses to. He can do periodontics, he can do endodontics, he can do cosmetics, but chooses not to if there are specialists around that may provide better value, may provide better quality of care. So there's plenty of work for general dentists. There's plenty of work for orthodontists and endodontists. There's plenty of work for oral surgeons. However, if you are in an area where there's scarcity of resources, I'm sure general dentists do oral surgery. I'm sure they do braces
Of
and
course.
they do all kinds of services because there's just not an oral surgeon around. So for physical therapy, we're generalists, but that specialization is so hard to find. And is it necessary? And is it rewarded more? Is it reimbursed to different fields? You also look into that the difference, the dissonance here is and this was not my words, this was Larry's words, is that dentistry rewards finesse and rewards good quality care by elevating your profession. So most dentists in leadership roles are still practicing dentists. Most physical therapists in leadership roles are now no longer practicing physical therapy because we almost did incentivize clinical expertise by elevating the state, like and myself included, right? I left clinical care for a while because look at me, I'm would go into a fancy pants startup world, but why would I see patients? But now I'm back seeing patients for that very reason is that like I feel now that clinical care. But there's a lot we can learn. We get stuck in this natural evolution of our field, feeling like we're the only ones that have ever done this. Dentistry has gone through their own evolution. General medicine has gone through their own evolution. Like crap, like surgeons did not wash their hands, did not have a sterile routine until 1950s. So surgeons would go into the OR like after picking their nose and maybe picking their pants and had all kinds of infections, right? Like and now like there's an entire sterile method. There's the entire process to ensure that there's no infection because the industry was able to evolve to recognize, well, maybe washing hands is good before we go into somebody's open cavity. So I think we can learn, we can evolve as a profession. And for this, like, so I will go just 2 more minutes into this, like geeking out, the history of science, right? So there's two foundational philosophies in science. There's Thomas Kuhn and then there's Karl Popper. And Karl Popper is the foundation of science through falsification. It's that whole theory, thesis, emphasis, like a study, and then prove or disprove that thesis. And then Thomas Kuhn believes in revolutionary discounting. So more of just a natural evolution by learning from priors without the falsification. So one is more of a rationalist, like Karl Popper is a rationalist, and Kuhn is a sociologist. It's just keep building on the priors. So where are we as a profession? Are we like, because to me, the last 25 years, we've been continuously disproving what we do. We're very good about shooting ourselves in the foot and saying that we don't have value, but we haven't really built on it. So like that, and I'll stop here.
But we keep doing things that are not valuable. I mean, I say we, every time I see this, I feel like I have to caveat. So let this count for the next 5 episodes. But I don't mean each individual person who might be listening. But you walk into the average PT clinic and there's folks doing things that are not value added and that just compound giving us a bad name. It compounds what the public thinks about us, that they share with other people. It compounds and accelerates how many people never show back up again for therapy because they recognize it's a waste of time. I mean, we disrespect ourselves, we disrespect the public when we provide that care, and yet there's lots of us doing it. My question is really one of frustration. How do we stop it? I mean, I thought 20 years ago we were going to stop it. And yet when we continue, part of it is because it goes back to payment, right? We're trying to cram in as many patients as we can. That requires overlap of patients. That requires giving patients things to do and passive activities, if you want to call them, or modalities to build time in. I mean, there's reasons for things, but we have to find a different way because if we don't, we're going to end up continuing the same problem and just talking around it. But what is the brass tacks issue? We have to stop doing stuff just because of volume and figure out how to be positioned differently so that we earn the right to be paid differently.
Yeah, I 100% agree with you. Is that it's the definition of insanity, right? Good old doing the same thing but expecting different results. So again, going into that Karl Popper's falsification theory, that it's that eternal search for objective truth. Like you're always searching for who we are. We're still in that search for identity that we were just talking about. But when does the search stop, and when do we start solving these problems? Like transitioning from the what to now what to so what. Like we're still on the what part. We're still labeling our problems, and we've spent decades labeling our problems. It's great. We know we have problems, but now let's move on to the so what. Like let's try to find solutions, and then let's get into the now what, which is the execution of these solutions. So, which is the problem solving is missing because what you were just referencing is that we're patching, we're sinking ship, and all we have is duct tape. So we just keep putting layers and layers of duct tape, but the water keeps coming up. So we just put an extra patch of duct tape. Sooner or later, you either run out of duct tape, or you get tired of of patching it, right? Like something has to give. You like we're here, and so even to reference like that volume problem. So if we are stuck in a fee for service model, like and you don't want to go into the value-based care, you're stubborn, you say, I'm happy working for pennies when I can work for more. I'm happy being where I am. Then what you have to do is at least work smart, learn to delegate responsibilities and resources, learn to utilize resources outside of yourself. I'm so tired of the argument that I didn't go into PT school to only evaluate. I didn't go into PT school like, no, you went to PT school to become a professional, to gain expertise in musculoskeletal care so that you can be an expert movement scientist, so you can identify barriers to improvement or movement and then diagnose them and treat them. You didn't go into PT school to hold somebody's hand and to be
That's
somebody's
right.
friend. Like you're not a social support animal.
Well, that's
Uh,
just another problem on top of
yeah,
the doing things that
right.
don't work problem.
But you're devaluing yourself. Like when we insist that I insist, I need an hour with a patient. If I don't have an hour with a patient, look, I will go into your 1 hour session. And this is like as a dinosaur physical therapist, as a grumpy old dinosaur physical therapist, I will absolutely show you out of that 1 hour, out of the 60-second, 60-minute session, there is probably only about 15 to 17 minutes of substance. The rest of it is non-substantiated low value care. So, and please come at me and prove me wrong. But socialization, patient centeredness, therapeutic alliance are important, but they're value adds. It is an essential part of our profession, but it does not need to be capitated by a 60-minute period. You can form an alliance by actually being honest with your patient and forming a decent plan of care. You can form an alliance by actually partnering with patient into their therapeutic trajectory, to their therapeutic improvement. You can form an alliance by actually giving your expertise and showing them that this is the threshold that you need to go to. But you don't form alliance by telling them your stories from the last weekend and telling about each other's family for 16 visits. You can do that in the first visit. You can do that in the third visit. But if you're still doing it and it's visit 16, it's become routine. You're not providing anything of value. So the substance is being a professional expert of your field and learning how to manage patients efficiently in a fee-for-service model so that you can see more patients. So you can actually have some external resources taken off some of the pressure from you or continue doing things as you're doing.
I mean, there's ways to make this work now and elevate us as a profession, and then that's one part of the solution, and getting other therapists to recognize it has to be solved is another part of it. But then it's how how do we behave and manage? It's really managing patients, it's not treating patients. The treating part can be carried out by PTAs, and they're excellent at it, and that's what they went to school for, and that's what we're supposed to be supporting. Our collaboration with them is supposed to yield this high quality actual treatment. And then how do we emphasize the dosing component and identifying, like, actually what people need based upon actual evidence? There's so many parts that it can get disheartening sometimes, thinking how do we get a whole profession to think differently about the way they care for patients, and what does that mean? Because getting anyone to admit that something that they've been doing for a long time they shouldn't have been doing is incredibly hard. In fact, it's why most behavioral health, doesn't doesn't work. Like, when you try to change, you have to be willing to admit you were wrong, or that you should have been doing something different, or that you're willing and able to change and face what comes up from that. And what we're asking when we casually say, "Oh, we'll get people to stop doing useless things like throwing hot packs on patients," we're also asking them to admit that they spent years, potentially decades, doing things that were not value add. And
Yeah,
so
how many psychiatrists does it take to change a light bulb, right? Like, it takes one, but the light bulb has to want to change. I'm actually like, so might as well like air it all out, right? I'm also I'm going to the CSM next week, and so it's an APTA, and I'm like there's a lot of negativity around APTA. I'm actually an APTA advocate. I think they're doing a great job with what they have. And I think they're doing their best, right? There's just a lot of different levers. People don't understand the complexity of
I
managing
know.
270,000 resources. It's not easy. So I think they're doing the best that they can, but they can always do better, and we can always just do better, all of us. But people complain about APTA not doing more. Would it be better tolerated if APTA took a prescriptive approach to it and said, no, okay, we signed this deal with CMS, and because of what we signed, every practitioner, every payer, I mean, every provider now needs to dedicate objective measures and needs to designate outcome measures and report on them for every single encounter. And if you don't, we're not going to get paid. But because of that, we're going to get X multiplier on our sessions. So that's a prescriptive model where APTA goes as a designator of the entire profession, negotiates with the federal government, and signs a deal that we can commoditize and create a premium reimbursement, but for that, we have to work even harder. And is that what we want? Or do we want more of a descriptive model, which is what APTA is? ATA tries to create policy, tries to pivot. Again, not ideal, not optimal, and certainly made a lot of mistakes along the way. But like you and I have had Drew on this podcast, right? We know that there's excellent agents, resources of our profession
Mhm,
within APTA that are trying, like Drew is trying.
mhm.
And so you can't expect APTA to channel all of your needs. Start doing it on the state level. We also had Cody and Jonathan on this show. Like, look at what they're doing in Alabama. That is positive. Agents of change in a single state, moving things along. Utah, so the Graham session had a couple of representatives from Utah. Utah has had an amazing
Mhm.
push towards autonomy, towards recognition as primary care providers, the first state to be recognized as primary care providers for PTs. Like, it can happen, but who's going to be the agent of change? Don't wait for APTA to give it to you. You have to take it. So
A lot of the best ways to create change is that grassroots state level, and once things become so obvious, then they it makes it easier to have a federal argument, right? So that's part of it. So one thing about the APTA that maybe will help listeners understand that are frustrated maybe with the professional association is, I'll make a parallel to another trade organization. The APTA, like we said, totally heterogeneous group. We have not only do we have inpatient, outpatient, early intervention, pediatric, outpatient, sports medicine, then we have subspecialties, and we have all the pelvic healths and all that other stuff. Okay. Let's look at I forget the name of the association for inpatient rehab facilities. just as an example. What do they have? They have inpatient rehab facilities, all right? There are some slight differences, but they're basically all almost identical. They're paid the same way. They have the same professionals working there by statute. Medicare Part A is their primary payment. And their major issue, their number one issue is choice. So making sure that this concept that there are some that are blocking patient choice, that's an issue. And the other issue is reimbursement levels. Those are their, so they can pound the pavement on just those two issues day in and day out, and they're pleasing 95% of their members, maybe 99%. Piece of cake. In fact, they should get everything they want. What do skilled nursing facilities do? Medicare, they complain about payers that are not fee for service, Medicare, and they complain about choice and payment rates. That's most of their advocacy. Look how homogeneous and simple industries, huge industries have it. It's like we've got 30 professions together. And yes, it's very hard, I can imagine, to prioritize for them. And they have made some leaps and bounds. We need so much more done at the grassroots level and by individual clinicians, not just saying, let them do it. We've got to own what really, really matters. And until we can present to stakeholders that have the incentive to care, that we add value to them and have others become our champions and support us. And until we can, honestly work at the regulatory level, work with CMS on like behavioral health providers have done to change our RVUs, our relative value unit weights, and to add value added codes to get more of the value that we can create. But then we have to be willing to scrap things that are useless care. It's a give and take. I
Hmm.
don't want to
Yeah,
argue and advocate for something that we're not willing to keep up our end of the bargain on.
yeah. The question is like, so if now, like, if be careful what you wish for, right? So everything that we're wishing for, it happens. Like it's a happy day, and we go and we celebrate, and there's confetti everywhere, and then the parade, and like we're all
Balloons.
convertibles and waving hands. And then day one of actual practice, and all of a sudden you have to maximize your impact, because you only have 4 visits that are guaranteed and the rest are out of pocket, right? Like, what do you do then? Can you maximize your delivery, your encounter, in limited number of visits? Or if you get X amount of capital to spend for per diagnosis, like look at the models that are coming out right now. Like, and we can go into that later, but it's the models that have just a flat fee per encounter, per diagnosis, per segment. And then you are part of the larger puzzle. So everybody's eating from the same cake, and you're only given a small piece. Can you suffice on that small piece? Can you quench your hunger from that piece? Because that's what we're arguing for in a way. But are you equipped for it? Is your staff equipped for it? Are you do you have enough infrastructure? Do you have enough capital to invest into technology that potentially will generate more revenue? Do you have enough ability to even understand what is value in MSK provision? And definitely, Dana, it's not hand holding. It's not like that. That is bonus, right? 51% substance, 49% nonsense. Substantiate your care by at least providing concordant care, not evidence-based care, but evidence-guided care. Evidence-guided care, like there's benchmarks. These are little buffers that go up when you're bowling, and these little buffers have to go up because I know that I am guaranteed to knock at least one, whatever you call those things,
The pins.
pins. There you go. Right, English is a second language coming to first. Right, and
I had to think for a minute.
right, I'm like, oh yeah, like, but it's a bowling ball. But like you have guardrails that, like, that's evidence guided care. You have guardrails that are clinical practice guidelines. You have guardrails that allow you to at least align. But so much of what we do, like, we're almost afraid, because God forbid if we have these guardrails and somebody says that you have to provide evidence guided care, I'm no longer going to be able to cup my patients beyond a certain threshold. Like on visit 76, I'm not going to be able to cup my persistent knee osteoarthritis. What am I going to do then, right? Okay, well, maybe you should look into literature and see if there's any clinical validity to cupping. Or if there's no clinical validity, can you justify what is the physiological artifact you're trying to contribute to, right? What are you trying to get out of it? So yeah,
What if the EQUIP model, we talked about this when Dr. Mark Gruner was on our podcast, the EQUIP model in Maryland, right? An episode of care is triggered by a PT eval. There's an estimated target price associated with what that episode should cost over 6 months. And if the PT does a good job and the patient doesn't get additional, unnecessary, avoidable care and interventions, the PT is given a portion of that savings. What would we do if that program came to your state and you were approached? How confident would you be that you could get into this type of a contract and you would be comfortable figuring out how to have some kind of a touch point, give the right amount of care, not too little, not too less, so that you did better than what was anticipated based upon the past? Would we be comfortable with that? Are all therapists listening to this like, yeah, I would thrive in that environment. I'm ready. Because that's the kind of thing we're talking about. Like, what is your value to patients' outcomes and helping them do better than they would have done in the old environment where they're free to they do whatever they want, they go get whatever test they want? How are you in developing a relationship with them that is beyond just come 3 times a week for 10 weeks and I discharge you? Those are totally different ways of, quote, managing patients.
sure, sure. I think so. Yeah, I don't know. It's a great question. I spoke to a young physical therapy leader that I like, Anna. Somehow we got connected, and it was a wonderful conversation. And one of the things that we spoke about is building a community. And my belief is that casting a wide net with big holes in it and going for big fish, or casting a more of a shallow net with small holes in it. Like, you catch more fish. There may be smaller fish, but if you're looking to eat, if you're not looking to catch a whale, but you're looking to catch mollusks, or if you're looking to catch little fish, then you need a smaller net with smaller holes to maximize your load. And so here, like, do you go after all 200,000 physical therapists to be the agent of change? Or do you just go after 10,000 physical therapists that are progressive, that are forward thinking, and allow them to take on leadership roles so that they can then guide the other 180,000 therapists? And I don't think we should be going after every physical therapist to be the agent of change. We shouldn't be disappointed when not every physical therapist wants to take on leadership role with the APTA. But there are physical therapists within every organization that want that opportunity to lead, that right now are being hamstrung by their administrators because they're just being told, know your place, right? Know your spot. So, yeah,
Right. There's a difference between what you can do in a local level and being able to influence enough folks to directionally advocate for the same short to midterm goal and agree that that's what we need to advance the profession, so that it opens up the other opportunities that are pent up and kind of stuck because we aren't visualized in the right way. I was just watching, okay, great example. I was watching a show, Landman. Have you seen it? Billy Bob Thornton.
I know what it's about. Yeah, it
Okay.
looks interesting.
So Billy Bob's father, I won't give you the whole background, but just the story about the physical therapist they hire. So Billy Bob brings his father, who's living in some kind of senior residence, to live with him. And he's got some back pain or whatever. He's got some mobility issues. So he says he's going to go hire a physical therapist
Okay,
to
I've
come
seen
work
that.
with
Yeah,
him.
I've seen that
Okay.
short. I think Michael Silva posted it. It's
Well, yes. So instead of hiring a physical therapist, he just hired one of the strippers at the strip club. Because, they just needed somebody to like float around in the pool with them. And the physical therapist stripper, she just held him on his back and floated him around, holding him. And they called it physical therapy. And that is how we are perceived in the public. We are interchangeable with basically anyone that moves somebody or that has anything to do with the body.
because we are terrible communicators of our actual skill set. We don't know, or we don't want to know, how to communicate what we do to the general public and why what we do matters. And then we haven't learned. So again, do we take a descriptive role or do we take a prescriptive role? Do we go by Karl Popper and try to falsify what we are and what we do? And I know I'm in a ways, and I will be the first one to admit, I am going against what I just said even before, which is like evidence-based practice, evidence-guided practice, which is all about falsification and all about proving yourself wrong. Or do we go by Thomas Kuhn, which is a paradigm shift, and just accomplishing enough of the threshold to transition to the next iteration, to the next phase? I think there has to be a balance between both. And so if the public doesn't know the difference between us and strippers, right, which is fine. Like I guess to
It's
me,
not
like
fun.
I saw that short. At least she maybe recognized that buoyancy has some kind of a value to his state of spinal health. It's still better than Queen Latifah, like swinging rubber bands with Common as a basketball player. I forgot that movie from like 20 years ago. She was a physical therapist, and Common was a professional basketball player. And so the entire, like, she's a physical therapist that was walking around with rubber bands and saying, "All right, like, you're ready to torture, or I'm gonna torture." Like, it's like, oh, all right, that's PT
But
also.
it
The
hasn't
type of
gotten any
khaki wearing.
better.
So
I it hasn't gotten any better, and to throw out, like, I gotta bring up CMMI, the Innovation Center models, at least once every time we talk. But the new access model, unfortunately, physical therapy is considered substitute spend in this model. So if you are a patient and you want digital health by a digital health MSK provider, and you go to one of those providers, you don't need a referral or anything. You can sign up, and just as long as you have a diagnosis, and that's not going to be very hard to get. And the idea is you use that, the digital health, the very, very low cost digital health code and service in lieu of physical therapy, because that's the goal, is to reduce the utilization of service, any traditional service, including physical therapy, to manage MSK pain. I mean, this is we're that is how this is the reality of perception, and perception is everything. This is how policymakers think about us. This is how the public thinks about us. And we own that. We're at fault. So, what do we
sure,
do to fix it?
yeah,
We have a public affairs problem. We have a brand problem. It's bigger. All the things we say, like, do we do this and this and this to grow? It's we have a brand issue that we need to solve for. And maybe that's it. Maybe that's the recommendation. We need to hire a public affairs team as a profession to take over and rebrand who we are to reality
make us
and
look
show all
shiny.
that we've accomplished.
Absolutely, we make us look brand new and shiny. Be like wag the dog. Be someone who can turn us into something of substance. I think if we go into that analysis of the scientific theory and go to the origins, it's forming hypotheses and then creating small experiments to show these hypotheses. I think it's small experiments like what we did in Utah. It's getting little victories. Building on little victories is the key.
Yep.
Don't expect a
Momentum.
big victory, right? So, yeah, still better days ahead.
Episode 26 app.